I think from this point onwards, we're just going to kick off today's session. My name is Murali, and I'm with the National Cancer Society of Malaysia. This is our 6th SK Dharmalingam series, which is really a series running every month on kind of discussing with healthcare professionals on various issues, insights pertaining to the management, detection and prevention of cancer at all different levels of the community. So today, a couple of special things. We I think are just crossing into the month of December, and actually it is still very appropriate that we actually get a bit of I would say percikan from last month, which was lung cancer month. And we're very fortunate and honored to be able to get with us today Dr. Mr. Narasimhan Satyamurthy. Dr. Nara is a consultant thoracic surgeon, and he works in Hospital Kuala Lumpur, and he is also the head of thoracic services for the Ministry of Health Malaysia. So first of all, again, since now we're recording this, let me formally again welcome Dr. Nara, and please allow me to thank him on behalf of all of us this morning and the society at large for being able to really help us out, spend your Saturday morning in sharing with all our colleagues quite a little bit about lung cancer. And so Dr. Nara is here this morning to talk about the early detection of lung cancer. What can you do? And we'll have kind of two little mini sessions in between. So where Dr. Nara will present, and then we'll have a little kind of break at which we can take questions at that point. So just a quick set of housekeeping as usual. I think the good thing after this series has been running for a while is everyone has kind of gotten used to the idea that we're coming in, the cameras are switched off and you can mute yourselves. And please feel free to tap in the questions into the chat box. As usual, don't forget there'll be two kind of code words, one at the end of the first half and then the other one at the end of the second half. And please put that in to kind of get your CME points right after. Okay, so without further ado, please allow me to welcome Dr. Nara and turn over the forum to him. Thank you so much, Doctor.
Yeah, it's a pleasure to be able to share some points on lung cancer management. Thanks, Dr. Murali, for having me this morning. I've given another talk earlier in the society building. That's probably about 3 or 4 months back, and I believe the attendees were quite happy with the information that I shared. So Dr. Murali asked me to talk on how lung cancer's situation in Malaysia, and I would like to share on how bad it is and what we can do as a healthcare provider and also as a public. So let's get started on this. First of all, we should know the place we are staying based on the 2019 statistics. In Malaysia, the population is about 32.6 million, and it's growing, especially with the MCO around the corner, a lot of people at home. So I expect there'll be baby boom sometime next year. Our area is about 330 kilometers squared, including Sabah and Sarawak. And this is what our previous health minister, Datuk Sri Dr. Zulkifli, got to say when he talked about health in one of the meetings we had. We are allocating 1/20th of GDP for health growth, 1/10 of government investment on human capital and productivity. There's a lot of health inequalities which led to socio-economic inequalities. We have a rapidly aging society where we're going to see a lot of our senior citizens is going to live longer and longer because our medical service is improving, and most of the diseases are well controlled and treated. So we're going to expect a large group of senior citizens, the geriatric group, and that means increase in healthcare expenditure. And of course, in keeping with that, you have an epidemiological transition of non-communicable diseases. And of course, like any services in this country, reform is an overdue. And we've done about 14 studies previously since 1985, and it's almost a unanimous consensus that a reform has to be done, but we're just waiting for the right time. So if you look at what Omar got to share when he published his cause-specific mortalities estimates in Malaysia back in 2013, that's about 7 years back, the main cause of death in the country is actually cerebrovascular disease and heart diseases. But if you just go down the graph, you'll find lung cancer is among the first cancer-related deaths recorded. The rest are all non-cancers. The lung cancer is the one cancer that's outstanding compared to other cancers. So it's quite safe to say that in the past 10 or 15 years, lung cancer has been the commonest cause of death in this country, and nothing much has been done about it because most of the cancers come late. Hence the reason why I'm tasked to give this talk to find out how we can detect them early and try to treat them with whatever expertise we can offer. So in the world scenario, we have nothing short of lung cancer being the champion in the incidence as well as the mortality. We have about 1.8 million lung cancer deaths alone in the whole world. That's back in 2018, I'm not sure now. If you compare the countries, Malaysia is somewhere above India and Thailand in terms of 5-year related survival for lung cancer. We are behind all these countries, including Singapore. We will go into the reasons why later. And in Malaysia, lung cancer, based on the statistics that we have in 2018, the commonest is breast, colon, and then comes the lung. And same goes, again, it's another way of expressing the common cancers in this country. The lung cancer is the third commonest diagnosed. And in terms of mortality, lung cancer is the highest cause of mortality. If you compare with breast, where they have the incidence of 47.5 per 100,000 population, the mortality is about less than half. But for lung, it is 15.3 per 100,000 population, and you have 13.3 per 100,000 mortality. That's like almost all the lung cancer patients are dying. That's bad. So, and if you look at stage of diagnosis, this is based on 2016 data we have, which was collected over the years of 2007, 2011. And most of our lung cancers are diagnosed in stage 3 and 4. Very few in stage 1 and 2, comparatively. And if you look at the relative survival of lung cancer compared to other cancers, it's way down at the bottom. So it's the worst survival that you can see in this country when you talk about cancers. And so based on all these statistics, we can summarize that lung cancer is the third commonest cancer diagnosed in Malaysia, and it's the commonest cause of cancer-related death in Malaysia. Almost 90% of lung cancers are diagnosed at stage 3 and 4, and it's got the worst 5-year survival. So I don't think we need any more reason to listen to the talk today, because we need to improve all this. All this got to change. We need to make sure that we have what China is having, we have what Japan is having, and we can relate to what they are having because, number one, they are much bigger than us in terms of population, but they can achieve better outcome. We need to know why. Let's look into it. So if you look at in this chart again, look at China, look at Japan. Japan may be the population similar to us, so we don't talk about Japan. You look at China, and in China, the population is 1.417 billion, and you have 28% smokers. Half of them are males. And if you look at the smoker population itself, there are 397 million. That's way more than our whole country's population. And in Malaysia, we have 22.8% smokers. That gives us about 7.4 million smokers. So you know that lung cancer, one of the highest risk factors, cigarette smoking. But despite these statistics, these staggering statistics in China with way more population in the high-risk group, look at the survival by stages in China. And comparing to Malaysian survival, this is China's statistics in 2013, this is Malaysian in 2018. So if you look at stage 1, A or B combined, their survival is almost, if you put an average to stage 1A and 1B, about 75%. And Malaysia, stage 1, 37%. So about half of what the Chinese are surviving, with huge population. Stage 2, it's about 50% survival in average. In Malaysia, 17.4%. Stage 3, 7%, 7.5%, and their survival is reaching 30%, 34%. So why is that? We don't talk about stage 4 because stage 4 is already palliative disease and obviously the survival drops, but with the current advent of immunotherapy and targeted therapies, the survival improves but costs a lot. So today we're talking about early detection. We concentrate on stage 1 and 2, a little bit on stage 3 because that's the commonest presentation to our country. So my point here is, why is that in China, where we have 300 over million high-risk population, they can achieve survival of at least 2 or 3 times better than our country with a population of 30 over million. And the high-risk population is about 7 million. It's a big question that we need to answer, and let's see where it goes. So I had an opportunity to visit Shanghai Pulmonary Hospital, one of the largest center back in 2019, because these questions were lingering in my mind and I need to know why. It's the largest chest hospital in the country. They have the dedicated center for thoracic diseases, comprising of NS, operating room, ICU ward, surgery, oncology, all in one building. And they are the largest center for thoracic surgery in the world. They perform, in 2018 alone, they performed 15,000 over lung resections a year. And I had the opportunity to share our experience of performing lung surgery in HK, our early experience during my visit there. And they perform about 90 to 100 lung resections a day. That's probably my statistics for 6 months. And they perform low-dose CT scans at a price of USD $30 to $40. That translates to roughly about 120 to 160 ringgit. You can't find that in Malaysia. In Malaysia, a low-dose CT scan costs about 2,000 ringgit. Why is that? We still need to figure out. And there's no lung cancer screening program in China. How can they get 90 to 100 lung resections a day without cancer screening program? And for the surgery that they perform, the patients pay up to 20,000 ringgit in government, not in private, in government. They have a subsidized system and most of them are insured. The poor public will be subsidized, but the one who can afford to pay insurance will pay and they get covered. So this is the amount of money they have to pay for lung resections. And their public awareness is very good. For some reason or other, the Chinese public will request for a CT scan as part of their medical checkup. So we will discuss on that later. In HKL, in the last 3 years, we've performed, since I started my service in HKL in 2017, after finishing my training with Mr. Hari in Sungai Petani, we have performed around 700 thoracic surgeries for various indications. Out of that 700 surgeries we performed, I've only resected 45 lungs, and that's about 6.4%. That's for lung cancers. And as compared to in Shanghai Pulmonary Hospital, their rate of surgeries for lung cancer is more than 80%. It would be safe to say 90% of their work is on lung cancers alone. And in HKL, the stages that I've got in my preliminary data, which is yet to be published, we got mostly about 70% of them presenting in stage 3A that we performed surgery. The rest are all stage 2s, like less than 10. Stage 1 is almost means about 6. So most of them are in stage 3A. And this is how stages at point of diagnosis for Malaysians in various cancers. And for lung, in the national data, we found that almost 90% of the patients are stage 3 and 4. We don't have a data specifically on how many presented in stage 3A, 3B, because previously there was no importance for it, but now we are starting to collect all these data to find out where can we improve. And this is a survival of various cancers. And if you look at lung, this is the green one that's at the bottommost of this survival curves. And as you go down the stage, of course, the survival becomes worse. And our best survival for stage 1 is somewhere at 37%, as I showed earlier. So why is this happening? That's a big question to ask, and I think we've been overlooking this in the past 10 or 15 years. Awareness. That's the first point that I would like to emphasize, because many of our people, although they are smoking, they don't think they can get lung cancer. They always say, my grandfather used to smoke for entire life and he lived until 90 years old. He never got any problem and he died well. So that's the simple excuse everyone has to prevent themselves from getting checked up. And this awareness is very important. Many of them don't believe that smoking causes hazardous effects to their health, not to mention other diseases like heart attack, cardiac diseases, colon cancers, breast cancers. They are just ignorant and refuse to accept the fact, and they continue smoking. So this awareness, the government is trying her best to make them aware by printing horrendous images on the cigarette boxes, but the rate of smoking is still high. You still have about a quarter of males in this country smoking. So I'm not sure how we can put it in them that it is dangerous and stop smoking. And if you're smoking, please get yourself checked. So that's number one. Number two is expertise. I'm the only thoracic surgeon in the government service at the moment. After Mr. Hari retired, and then we have Mr. George and Mr. Rahmat, who are in the private practice at the moment. They're still offering the services in the private practice. And Mr. Prem is another thoracic surgeon in Penang Medical College. So there are only a handful of us. And the limitation of expertise have prevented the service to be translated into practice. To assist the respiratory physicians to treat these lung cancers by performing resections. And of course, we have our cardiothoracic colleagues who are helping us to treat lung cancers, but they are overburdened with the cardiac work. The waiting time for a bypass surgery in the government service has gone up to 3 to 4 months, and patients are waiting in the wards for months to get the surgery done. So if I really appreciate their effort in helping in the thoracic component as well. But it's just not enough. We need more expertise. At the moment, I'm training 3 thoracic surgeons. One of them is in Taiwan, finishing a fellowship for a year. 2 other surgeons are with me now, and we are planning to get at least 10 more thoracic surgeons trained and distributed around the country to establish their service in Sabah, Sarawak, East Coast, West Coast, North and South. So in that, expertise will be taken care, but it'll take time. And infrastructure, there's no one-stop thoracic center in Malaysia. In fact, there's none in Southeast Asia except in Philippines. They have a lung center in Philippines, but there's no other thoracic center. The good news is in HKL, we are in the planning of establishing a national chest center in coordination with IPR, Institute Perubatan Respiratory Negara, thoracic unit in HKL, radionuclear unit, and various other supporting departments. We are in the plan of building a respiratory center. So that may take another 10 years, may take 15 years, but the plan has started and it will be a one-stop center for the Malaysian public. So the motto is always detect early, treat early, and look at better outcome. So at the moment, we have done our lung cancer screening pilot program. We were started in IKN, it failed. We've attempted to collaborate between NGOs, private stakeholders, and government institutions for screening, failed. At the moment, free lung cancer screening is conducted by Lung Cancer Network Malaysia. We are awaiting the outcome. And it is really good that there is a lung cancer network who's looking into this issue of detecting lung cancers early, because government hospitals are just overburdened and under-equipped to perform low-dose CT scans as medical checkup. There's just not enough staff to read the CT scans. The funding is not adequate to even perform CT scans in cases, in disease patients, but this is doing CT scans in patients who are high risk and otherwise they are asymptomatic. So comes to the question, is lung cancer screening is the real answer to detect lung cancer early? Or why are we putting the excuse that we don't have lung cancer screening and we can't detect lung cancer early? In China, they don't have a lung cancer screening program, but they're detecting the cases early. So if you look at lung cancer screening, who should we screen? Those males who are more than 40 years old or 20-pack smokers, female Southeastern Asian non-smokers. That gives a coverage range of almost all the population. Because if you look at male more than 40 and female Southeastern Asian non-smoker, that's already giving about 50% of the population in the country. So that pretty much, you have to screen everyone who's more than 40 years old, male or female, smokers or non-smokers. When to screen? More than 40 or more than 60 years old. And how frequent to follow up them when you find that small lesion? The GGOs, they call it, the ground glass opacities. If they are less than 5 millimeters, are you going to do the CT scan 3 monthly? And if it is growing, you need to biopsy them, you need to localize them, and then you need to have yearly interval scans, or you want to do it 2 yearly interval. No one actually knows the right answer. It's just based on the practice that is done based on the available logistics. So it is really a gray area. And that's why lung cancer screening has not picked up in many countries around the world. And Nelson trial has been conducted, published in 2018, and they have proven that CT scanning decreased mortality by 26% in high-risk men and up to 61% in high-risk women over a 10-year period. That is very true and is very good if you can perform the low-dose CT scans as for lung cancer screening with availability of all the facilities and staffs to carry on the screening program. But if you don't have it, we can't keep saying, giving that as an excuse for not detecting lung cancer early. And in Malaysia, We have done our low-dose CT for lung cancer screening as health technology assessment, and they have reported the financial implication, assuming participation of 100%, the financial implication for lung cancer screening only using low-dose CT scan among smokers from 50 years to 69 years old who smoked more than 15 pack years was 179,495,980 ringgit. That's if you take 50 to 69 years. But if you screen up to diagnosis range of 299 million to 333 million per screening. So that is what's the cost of lung cancer screening up to diagnosis. But if you increase the 15 pack years to more than 25 pack years, the cost comes down to about 103 million to 193 million. But still, that's a lot of money to use for screening to detect one lung cancer out of 100 screenings that's performed. That's about 1 to 2% of diagnosis. So the final recommendation from the health technology assessment from the Ministry of Health is that LDCT may be used for lung cancer screening among the high-risk group in a research environment or for research purpose only. We can't use that to treat or detect early lung cancer for the public in a non-research environment. So to counter all this, we need to increase our preparedness. And among the things that we are doing at the moment in Ministry of Health is that the infrastructure we are building, as I said, a one-stop center for chest disease. A location for LDCT is being sought to be performed in the government hospitals, not as a screening, but as a medical checkup for high-risk patients. We can't initiate screening. It has to be a medical checkup with the consent of the patients. Training, more thoracic surgeons are being trained, awareness to be made widely known the benefits of detecting lung cancers early. Early disease are almost always asymptomatic, and the only way to detect is by LDCT and identifying the high-risk group, and that's where the primary care physicians come in. What can the public do? The public should equip themselves with knowledge. They have to know what is lung cancer, how it happens. It may not only those who smoke, but also those who are non-smokers, female, and because of the EGFR mutation that is the incidence is quite high among the Asian, up to 40%. So they should know that if they have a family history of lung cancer or family history of other cancers, they must be aware that at least once in their life, they should have an LDCT performed. Invest in your health, include LDCT as part of your medical checkup. And as for the primary care physicians, they have to look for patients with high risk to get lung cancer and not look for symptoms of lung cancer because that will be too late. You need to screen your patients when they come to the clinic to look for the risk that are they in the high risk group or not. If they are, advise them to perform LDCT. You can identify the hospitals that can perform LDCT for free or discounted prices because, as I mentioned, Lung Cancer Network is doing an excellent job in bringing the LDCT to the public. And once it's done, review the scan results and refer them to thoracic surgeons or respiratory physicians early. Don't plan a biopsy yourselves. Don't delay the patients. Send them to the experts to continue their management, and we will send them back to you, the feedback to you once everything is sorted, and the patient will thank you for identifying them early and getting them sorted. And these are the efforts by Lung Cancer Network, which I like to share. And these are the hospitals that's giving free LDCT at the moment. You can fix around Klang Valley, and you can get them done. If you're in the high-risk group, please reach out to any one of these hospitals according to the time that's given, arrange for an appointment, get a free LDCT, and get yourself screened in a way. Conclusion, ladies and gentlemen, LDCT is a safe way to detect early lung cancers. include LDCT in medical checkup, consult respiratory physicians or thoracic surgeons during the follow-up. Government hospitals are in the process of offering LDCT for high-risk groups. Not yet, but in the process, we are still in the discussing stage. And private hospitals should bring down the price of LDCT, just like how China is doing, make it affordable for the common public who can't afford to pay so high, and that hinders them from getting themselves checked. Although they smoke, but somehow they can't afford to fork out money to do LDCT. So with that, I'd like to thank Dr. Murali. Back to you.
Doctor, thank you so much. And I think we can take a couple of more questions. We can take a couple of questions. I think there's some questions already, Doctor.
Sure.
And yeah. Okay. So there's one question from, I think, one doctor who says, oh, okay. So I think more of a comment that we now see young patients with lung cancers below about 20 years old. So I think just perhaps an important question to kind of ask, Doctor. Any ideas on kind of how do we, and because I'm sure you spend quite a bit of your time speaking to patients on the importance of doing screening, and how do we start the conversation to patients in the sense that when we start talking about this idea that you should do screening and you're a smoker, any tips, Doctor, how to kind of approach the subject? What works? I think this is a question all of us are kind of hoping to get today.
Okay. To be honest with you, I don't talk to the patients to encourage them to screen, because most of the cases referred to me are those who are already diagnosed with lung cancers. So for me, it's just to decide whether I can do the surgery on them or I can't do the surgery. But I do tell their children or friends who accompany them to the clinic to get themselves screened, and that will be quite effective because they've seen their relative or the father, mother having lung cancer, and they themselves smokers. So they were quite motivated to do the scans, and they normally come back to me in the next visit and show the LDCT and say that, doctor, it's normal. So that's how I get these people checked. But for the public out there, especially the primary care physicians who are seeing patients in the clinic, all you need to do is just ask them whether are they smokers, and if they are smokers and they are more than 40 years old, just have to tell them that one of the things that you should invest on besides the cigarettes they're smoking is that to get the lungs checked. And the best way to get lungs checked if they're asymptomatic is not by chest x-ray, because chest x-ray most of the time will look normal. So you can't pat yourself at the back, look, I've been smoking last 30 years, my chest x-ray is normal. No, you can't do that. You have to do a low dose CT scan, and that advice must come from the primary care physicians. And when you give that advice, the problem is not many of them know where to get the LDCT. They'll end up with a government hospital. In government hospitals, we can't offer LDCT because the resources are just too extensive, and there are not enough staffs to read the LDCT routinely. And so they have to find their own resources. They have to go to the hospitals that I just put up in Klang Valley, and this has to be done throughout the country. So every private hospitals in every state must take their social responsibility to offer the LDCT in a cheaper price, or free for that matter, because that is part of their commitment to the society to reduce the incidence of detecting lung cancers late, and directly leading to a better outcome of lung cancers if surgery is performed early. Yeah, Dr. Murali, you can. Hello. Well, I think there's some connection problem with Dr. Murali. Anyway, I'm reading some questions in the chat. How frequent should a person go for LDCT? Well, you can go for LDCT at least once in your lifetime if you are in a high risk group. And if there's normal finding, you can do it every 5 years once. If you have a GGO, means there is some abnormalities seen, ground glass opacity, you need to repeat the LDCT at least 3 to 6 monthly based on the advice given to you by your respiratory physician or thoracic surgeon. And then we will decide whether you want to remove that lesion or you want to continue the surveillance. If you want to remove the lesion, then we need to do localization, biopsy, and etc. So that is a long list of investigations to be done for the LDCT. What is another question is on what is the positive and negative predictive value of the low dose CT scan? All right, I can't give you the results offhand. I can't remember the positive and negative predictive value. You can look at Nelson's study. You just Google Nelson's study on lung cancer screening, and the paper is available to be reviewed, and all the predictive values and the statistic results are all there. So please look into it. And there's no doubt that LDCT is the way to go to diagnose early lung cancer. So knowing and comparing one or two difference in the percentage will not change that fact that LDCT is the way to go to diagnose early lung cancers. And government to take strict measures to stop smoking. Maybe we should follow some Western countries to charge the patients fully when they are admitted for their social habits, induced illness, and insurance companies should pay their claims. I don't take any trainees if they are smokers. We do see young patients. Well, yeah, that's a huge policy change there. I'm not sure how far we can encourage that to happen in the policy level. A lot of work to be done, and I hope I can bring this up in my meetings later on with the administrative staffs. I'm not sure what happened to Dr. Murali.
Hi, doctor. Sorry, the office internet has switched off, so I'm just dialing it back from the phone.
All right.
Right.
I just tried to answer some questions in the chat box.
Oh, lovely. Thank you, doctor. I was going to ask you as well, and this might be quite relevant because now we actually see quite a few people who are not fitting the bill, meaning you see younger females who are non-smokers who are actually now starting to present with lung cancer. So any kind of thoughts for general physicians actually seeing people? Should we consider things about like secondhand smoke, doctor? Do you think this is a question worth asking?
Okay, young females who are getting this lung cancers, that's mainly due to the genes. We were looking at mutations in this so-called gene EGFR, which was previously not highlighted. And recently we found that many of these Oriental patients who are even less than 40, non-smokers, not even exposed to secondhand smoking, getting lung cancers. So they found that it's as high as 40% of this Asian population having mutation in the EGFR gene, and that's the cause they're getting lung cancers. So the way to ask in the primary physician level is that it's as simple as like taking any family history to a patient. If they have any family history of cancers, especially lung cancers, colon cancers, and if you can detect that the aunties of the patient have got cancers, the sister has got cancer, that means the risk is becoming, they've already fall in the high risk group. And in this situation, it's worthwhile, besides telling them to do the entire blood tests to detect cancers, it's worthwhile to advise them to perform besides colonoscopy and upper scope, you can also perform a low dose CT scan. So this is how we can detect this group of high risk females who are non-smokers. And everyone will be wondering, I didn't smoke, I'm not around anyone who's smoking, why should I get lung cancer? So that is one way that I look at. I'll be talking about it in my next presentation as well, to identify this group.
Will do, Doctor. And I think perhaps I think one of the important insights you're sharing with us, and just kind of voicing it back out so that you can reaffirm to us. One, I think for people who are coming in above 40 years old, and especially now in December, you'll get everybody coming in for their regular annual health checkup. I think you're saying worth to kind of discuss their smoking history. For a lot of primary care physicians, I think this is something we try to avoid, just in order to, sometimes not make the patient unhappy. So we skirt over it. Yes, doctor. And maybe I think the second thing that, which is an important insight they're sharing with us is, look, don't depend on the chest X-ray.
Yeah.
What is this? Doctor, when you send someone for a low dose CT scan, and sometimes you get these very innocuous little lesions, as you correctly pointed out to us earlier. Do they, and sometimes they're very small, what do you do with them then?
Okay, so this is the problem with screening. When you have a screening program, you need to have a follow-up plan if you detect a small lesion, and this becomes very taxing to the system, and that's why many of the screening programs in many countries fail. So in most situations, when you have a small lesion, ideally the CT scan should be repeated the next 3 months to see if the lesion is becoming bigger. And you have to look at the rate where the lesion is becoming bigger. Is it more than 1 millimeter in every scan? And you need to have a special program to store this data and to follow up these patients. And some patients even get the CT scans repeated up to 10 years. And the lesion may just grow by 1 millimeter in 2 years, and then you continue doing that. So if that were to happen, it's going to tax. Imagine if you have 100 patients doing this in the system, it's going to tax the entire service, and we don't have that much of capacity at the moment to offer this. So coming back to the question, if you have a small lesion detected in the LDCT, you need to do the scan 3 monthly to follow up, and you can have an option where the surgeon can localize the lesion and resect it before it becomes any bigger. So this is what we can offer at the moment, and you can do a very minimal surgery of sublobar resections, meaning you only remove that part of the segment where the small lesion is involved, be it 5 millimeter or 1 centimeter.
Right. Yeah, thank you, doctor. I think that is really an important point, and just kind of ask as well. Usually, when you send off the patient for a low dose CT, they go to the diagnostics division of a private hospital, and then they sometimes most likely will come back to you to ask where do I go if now I've picked up something funny. At this point, what is this? Would be your opinion? Could they go to any kind of respiratory physician, thoracic surgeon? Ideas, doctor.
Okay. When you have positive finding in the LDCT, the primary care physicians should refer these patients to a respiratory physician or the thoracic surgeon if they are available in your state or your district. And there are not many around that in terms of thoracic surgeons or cardiothoracic surgeons. So if you have a nearest respiratory physician, please refer to the respiratory physician. They will know how to take it from there, and they will correctly direct the patient to the surgeons if surgery is indicated based on the LDCT. Um, Even if you get to a surgeon, what we'll do is that we will see the scan, we'll see the results of the size of the lesion, and we have to talk to our interventional radiologists whether can they localize the lesion and biopsy the lesion. It's not easy to biopsy a 1 centimeter lesion in the lung because number one, the patient is still breathing. They don't stop breathing, and the lung moves when the patient breathes. And it's so to localize and get exactly at that 1 centimeter or 5 millimeter size lesion is pretty challenging. So some radiologists can do it. Some radiologists will say, let's wait. So what I will do is that if my radiologist cannot deliver the biopsy, I will repeat the scans 3 monthly or 6 monthly. We'll look at the size of the tumor. Is it increasing in size? And if it is increasing and my radiologist say can't biopsy accurately, I will do a localization technique and we'll view the lesion intraoperatively and remove the lesion for a frozen section. And during the frozen section, I will know whether the lesion is in the lung tissue or not. If it is in the lung tissue, well and good, the lesion is removed and you'll get the results, the proper histopathological report within 2 weeks of the surgery. That's pretty much sums up of what will happen to a patient if they detect a lesion.
Right, doctor. There's a question, I think, from Dr. Lui, and Dr. Lui asked, with regards to gender prognosis for lung cancer in terms of staging, any insights, doctor? Also, the male to female ratio in lung cancer distribution.
Gender prognosis for lung cancer in terms of staging. Well, so far we found that females who are detected with lung cancer, they tend to do worse than males because of the genetic predisposition, and they tend to be asymptomatic until late stages. Somehow the smokers will have some sort of cough or difficulty in breathing. They'll get some chest x-rays done, and some of them will have COAD and CT scans will perform and they detect early. Those asymptomatic group, especially the females, the unsuspicious group are the one that do not so great, especially in the Malaysian setup. And they tend to be quite difficult to manage in terms of the chemotherapy, radiotherapy, and also the targeted therapies that we have nowadays.
Okay, doctor. And there's one more question on whether, I'm sorry, this is running out. Let's take this last question. I'm then going to let Dr. Nara do the second segment. What is this? There's a question on whether squamous cell carcinoma, adenocarcinoma, which one has a poorer prognosis in terms of lung cancer?
Adeno-CA generally have better prognosis as compared to squamous CA. It's not like there's so much difference in terms of whether adeno is way better than squamous or not. Both of them have got bad prognosis. But if you got to choose, if you want to have if God says you must have a lung cancer, choose adeno or squamous. Better to choose adeno. Squamous tend to be a bit more aggressive. They tend to metastasize to organs more aggressively, and but both can be treated well adequately if they present early, if detected early. So to answer the question, squamous has got poorer prognosis.
Okay, got it, Doctor. So I'm going to kind of let Dr. Nara go into the second segment. And just before that, I think it's worth sharing the first code word, with I think is the byword for this first segment, which is LDCT. So however you write it, whether in length or not, low dose CT is your first code word for your attendance, LDCT. Thank you. Doctor, could I kindly invite you to go on to the next segment?
Yeah, sure. Let me just share the slide. Let me know if you can see the slide, okay?
Okay, hold it, Doctor. Yes, we can.
Okay, good. This is my second part of the talk today. Thanks to the participants for staying on. Basically, it's lung cancer management, early versus late detection. So we know from the survival graphs here that if you detect lung cancers early, the survival is as high as 73%. But if you go to stage 3A or 3B, the survival drops drastically to less than 20%. So, and again, I'd like to highlight the slide. The survival by the IASLC or the TNM staging is an average survival for the entire population that they have sampled throughout the world. But if you look at country specific like China, they have better survival than what they've quoted in the TNM staging. And obviously in Malaysia, our survival is not as good as either one of them. And this is true for all the stages that we can see. And what do we mean by early lung cancer or locally advanced lung cancer? So if you have any tumors less than 5 centimeters without mediastinal nodes, without metastasis, that is stage 1 and 2, and we call them as early lung cancers. Stage 2B is a bit, it's a gray area, but you can consider them as not early. Some surgeons will still say that 1 and 2 generally is early lung cancer, and anything that is more than 5 cm, if they have got nodes in the mediastinum or hilar, and without any metastasis, we call them as stage 3. And stage 4 means they already have metastasis, either single lesion or multiple lesions. So we're not going to discuss on metastatic lesions. That is already in terms of palliative care. And we try to prevent that from happening. So we will only talk about early lung cancer, what will happen if you detect early, and how more difficult the surgery will be if you detect them in the locally advanced setting. So again, the discussion on how to detect early, as we discussed in the Q&A session earlier, identify high-risk patients, male, more than 40-year-old, and if they're 20-pack-year smokers, female, Southeastern Asian of descendants, non-smokers, family history of malignancy. So you have a big population to screen here, and counsel them regarding the benefits of performing an LDCT, and enlighten them regarding the risk of getting lung cancers. And once they have informed about the risk of getting lung cancers, after this talk, you can tell them how different the treatment is if you detect early as compared to late. And of course, direct them to the hospitals offering LDCT, get the scans done, and refer them accordingly to the respiratory physicians or thoracic surgeons. So these are the symptoms, the features of patients with early versus late. Usually in terms of symptoms, for the patients with early lung cancers, they are almost asymptomatic, they're perfectly normal, whereas the late presenters will be symptomatic. They either have prolonged cough, they may have hemoptysis, means coughing out blood, and they may have weight loss, no appetite. So these are already signs of late symptoms. Most of the findings of the lesion, those present early, will be incidental, usually during medical checkup, when they perform CT scans, when they met with an accident, or they went for a cardiac checkup and cardiac scans are performed, and they detect some abnormalities in the lung field, and that's how they get picked up. Those with late presenters, you can do a chest X-ray and find a lesion. If you can find a lesion in chest X-ray, that means they're already in the late stages of presentation, most of the time. For intervention in patients with early lung cancers, surgery can be done by keyhole method. We call it video-assisted thoracoscopic surgery. Those presenting late, they may need open surgery. I'll show you the pictures, the difference after this. It depends on which center you go. If you go to a high volume center performing lung surgeries like what we do in HKL, we can execute VATS in late stages as well with equal results. But it may not be the case across the country. So present early, it can be done by VATS in most centers. And early lung cancers, you may avoid chemo or radiotherapy, because in stage 1, if the surgery is done well with no nodal involvement and margins are well away from the normal tissue, the oncologist may not even give any treatment after the surgery. But when you come late, the patient will be subjected for chemo or radiotherapy. And of course, the survival is way better for early, as you've seen in the charts that I shown earlier, up to 70%. In China, they're giving survival up to 80% for lung cancer. That's unheard of before. But if you come late, poor survival, less than 20% 5-year estimation. And of course, in early presenters, you return to your activity of daily living faster because the surgery is in a minimally invasive manner. You don't go for chemotherapy, and you return to your daily activities. You can go back to work and you carry on with your normal life. But if you come late, you need to go through the chemotherapy and radiotherapy, the side effects that comes along with it. And you have more pain because the surgery will be longer immobility, and so on. So this is pretty much sums up how do you detect early, and what are the features to look for, and what are the benefits if it's detected early versus if they come late, what to look out for, how to determine they are early or late, and what is the advantages and disadvantages of getting the cancer treated early. So this is the surgery that I've mentioned earlier, the keyhole surgery, which we perform by uniportal. Means you have about 4 centimeter wound in your chest. All the instruments are through the wound, and the whole lobe or the segment that is involved is removed through this. At the end, you get a tube through the same hole, and the wound is closed. So it's a very minimal access surgery. The patient, most of my patients, the next very day they are up and walking. We don't have urinary catheter on them. They start to take orally faster. The pain is way lesser. And if everything is good, they normally go home by day 2, maximum day 3, based on the drain output. Compared to if you come late, you get this, a huge thoracotomy wound. Sometimes you need to resect part of the rib or crack rib to get access to the tumor. The pain will be more. They'll take longer to come out of the bed. There'll be discomfort in lifting their arms. And then on top of that, they may be subjected for chemotherapy and radiotherapy. So this is the difference. You come early, we sort you out with this. You come late, this is what will happen to the patients. I'll show you the surgeries that can be performed. Let's look at the surgical options of lung cancer when you come early versus late. So if as I said, if you detect tumors of 1 centimeter or 5 millimeter when you do LDCT, we can offer sublobar resection, whereby we don't remove the entire lobe of the lung, we remove the segments along with the vein and artery and the bronchus that supply the segments by minimally invasive manner. At the moment, lobectomy is accepted as a standard of care for tumors more than 2 centimeters. But less than that, we go for sublobar resection, and it can be used for stage 1 peripherally located tumor. That's the indication that I have to perform segmentectomies. To be very honest with all of you, I have not get even one patient to perform a decent segmentectomy in a stage 1 peripheral located tumor. All of them come in late stage 1 or early stage 2. So I'm not happy performing a sublobar resection. Most of them will end up with a lobectomy. The only sublobar resections that I perform is on metastatic disease for parenchymal bleeding. That's a totally different topic. So I'm yet to find a patient that is suitable to go for segmentectomy in Malaysia. Open thoracotomy or multiportal VETs or uniportal VETs. These are the options we have to perform lung resections at the moment. VETs lobectomy is the gold standard at the moment for early lung cancers. This has been proven by a randomized control study in UK called the Violet study. So just like how cholecystectomy, removing the gallbladder was done open, and now the gold standard is by laparoscopy. For lung cancers, VETs lobectomy has become the gold standard for early lung cancers. So if you have early lung cancer, the surgeon should offer VETs lobectomy, none other than that, unless if they are not comfortable with it, then the patient should know that they can get a second opinion to get a VETs lobectomy done. And that should be the minimum care offered for early lung cancers in this country, based on the randomized study that we published. Reason is VETs results faster recovery with minimal morbidity and oncological outcome. Both thoracotomy versus VET, they found that there's no difference, and you need to get good lymphadenectomy performed by VETs. In my center, the rule that I have for my trainees is that for the right side lobectomies, you need to have minimum of 20 lymph nodes harvested, whereas for the left side, you need to get at least 15 lymph nodes harvested. And if it is not seen in the HPE results, then need to relook at how the videos, look at the videos of the surgery, and need to find out why they can't get. Is it because the patient do not have nodes, or the patient had nodes and you didn't completely remove them? So this will be a post-mortem in our academic days in the hospital. So that's how I set the standard of surgery and quality control to make sure that there will be no difference in oncological outcome when you do thoracotomy versus VETs. And of course, the surgeon's experience. You can't have low volume center surgeon performing equally good VETs as compared to a high volume center. You need a good number of cases to know that these are the problems that you may face and how to troubleshoot them if you were to encounter during the surgery. And you need to look for high volume centers to perform this. So this is pretty much the evolution of surgeries for lung cancer. Classically, it was formed as posterolateral thoracotomy with this kind of wound, and then the wound has become smaller. They call it muscle sparing thoracotomy, and then went on to multiportal VETs. We have about 4 to 5 holes inserted to remove the lung. And now we have evolved to a single pot where more the instruments are inserted in the same pot, and the lung, the specimen is removed through the same hole, and the chest tube is inserted in the same hole. So these are the investigations we do before the surgery: blood investigations, cardiac function, pulmonary function. This is a thoracic cardiac revise index, where we subject most of my patients who are more than 60 years old, and they have to make sure that these criteria are fulfilled before the patient is subjected for surgery. And if they have no such issues in the cardiac, then they proceed to pulmonary function tests. Lung function is assessed, And then if needed, we proceed for cardiopulmonary exercise test to see the Cmax, Vmax, and then we'll have an MDT to decide whether the patient is suitable for surgery or not, and subsequently subject the patient for surgery. As I mentioned earlier, if it's early lung CA, stage 1 and 2, we perform VET sublobar. This is what I mean by segmental resection of the upper lobe. We just take out the apical segment. We don't take out the whole lobe for the tumor here. It is less than 2 centimeters. Anything more than 2 centimeters, perform a lobectomy where the entire upper lobe is removed. Here, you just take out part of the upper lobe, you preserve the lung function. Here, you take out the entire upper lobe, you only have 2 other lobes in the right side to continue. So this is the one of the videos that I like to share. It's about a minute, 2 minutes long on segmentectomy and how easy it is. It's actually not for lung cancer, it's metastatic tumor of osteosarcoma. And for metastatic disease, we need to preserve as much lung tissue as possible because you have to do a metastectomy. And you can either remove the tumor by a wedge resection, but if it's too near the hilar and you're not sure that the margin can be achieved or not, you can perform a segmentectomy where you can identify the vessels supplying the apical segment separately. So I've identified earlier the artery that has gone up to the apical segment, and I'm dividing that now. And then I'm dividing the vein that is draining out from the apical segment. And subsequently, you need to identify the segmental bronchus to the apical segment, test the segmental bronchus actually only deflates the apical segment that you need to remove, and then resect the apical bronchus, and then remove the apical segment based on the inflation-deflation test that we performed earlier to determine the margin. And by doing this, you're preserving about 2/3 of the upper lobe. You're only removing 1/3 of the diseased upper lobe. And the rest of the lung is there for the patient to carry on with almost normal activity. And you need to examine the specimen to ensure that the margin is clear and lung is expanded and the surgery is over. So this is what I meant by a segmentectomy. It means a small portion of the lung tissue is removed. And this patient will go home in 2 days, and that's how big the lesion is. And this can be done if the cancers are detected early. If you have a lesion less than 2 centimeters, I can offer this surgery. For locally advanced lung cancers, although some studies have shown favorable results in the surgical arm, you can counsel the patient and give them the option whether you can go for definitive chemoradiotherapy or you can take the arm where there's including of surgery as a multimodality treatment. Both of them have comparable outcomes, but in the local setting in HKL, our multidisciplinary team for lung cancer will always decide to go for surgery because the previous studies have looked into thoracotomy versus chemoradiation. Now we are doing VETS lobectomies. The morbidity is way lesser, the pain is way lesser, the outcome is equal, the oncological outcome is equal to open surgery. So our oncologists have realized that by performing VETS lobectomies, they actually reduce the chances of giving these patients radiation, and that improves their survival because there are studies that have found that post-operative radiotherapy has actually got no benefit after surgery. So with that context, most of the patients in HKL or referred to HKL will be subjected for VETS lobectomy and then chemotherapy without radiotherapy if the margins are all clear and nodes are all cleared. And this is where the patient selection is very important. We need to find out what the patient wants, what the family member wants. Is the patient suitable to undergo surgery? Is their lung function, lung reserve adequate and for their survival after the lobectomy? Can they be brought into the surgery and out safely? Will the anesthetists be happy? All these issues will be discussed in the multidisciplinary team meeting with the patient, and the results of the discussion will be shared with the patient there and then, and they will be given the opinions of all the experts involved in their management, and a decision for surgery will be made subsequently. And this is what we do for most of our complicated cases. And most of the patients will agree for surgery because they don't want to go through the radiation. We can't promise them there will be no chemotherapy. We will always tell them that it depends on the histopathological results. And they are very acceptant to this kind of counseling, and they will normally agree for surgery. So this is one of the editorials on optimal treatment of stage 3A and 2 non-small cell. As I said, it's a never-ending story. No one is going to be able to prove whether surgery and chemotherapy is superior to chemoradiotherapy alone without surgery. The debate on optimal treatment will go on, and some surgeons would argue that resectability is a state of mind. And the time being, there's no single optimal treatment that can be recommended. Incorporation of new diagnostic and treatment strategies such as recently imaged targeted therapies and immunotherapy evaluated in well-designed clinical trials will open up new horizons. It is hoped that this will result in better overall survival in this gray zone of potentially resectable lung cancer. So the reason why I'm telling you all this is that when you detect the lung cancer early, we don't have to crack our heads with all these jargons. It's very simple. In early, bring the patient in, do the VETS lobectomy or VETS segmentectomy, get them out, refer to oncologists if need chemotherapy. Most of the time they don't, and they carry on with their life with subsequent follow-up scans in 6 months and so on. But if the moment they reach stage 3, stage 3A for that matter, there'll be a lot of issues to discuss with the patient, with the oncologists, with the anesthetists, with the respiratory physicians. The lung reserve may not be that good. So it becomes more complicated. The surgery can be done, but it becomes more complicated. So that's why detect early. It saves me a lot of time, saves my neurons, and I can work longer. So what is happening in Malaysia? Most of the operated lung CA patients are from stage 3. So as I said, we either go for upfront surgery or after chemotherapy. Limited resources for oncologists to start chemo in all patients. If the tumor is resectable and lymph nodes can be cleared, surgery is offered upfront. And immunotherapy and target therapy are very expensive. It is coming to the limelight now. In fact, I'm going to give another talk next week in Malaysian Thoracic Society conference, going virtual, on role of immunotherapy versus surgery in stage 3 lung cancers. So, well, I'm telling you my argument in that talk will be the cost. It can cost a patient up to 150,000. This is subsidized cost, not purely private cost. It's subsidized cost. And for immunotherapy to be used for a year, it can cost a patient up to 150,000 ringgit. And if it's effective, they may continue it further. So it is just not practical to expect our public to pay that much of money out of their pocket. And most of them will not be compliant to the treatment, probably in 1/3 of the cycle. And what's the point even starting if they can't comply? So this is the reason why we need to detect them early without coming into all these complicated conflicts between whether to offer surgery, chemotherapy, chemoradiotherapy, immunotherapy, and so on. So this is what happens when you detect the tumor late. So we do perform tumors. This is a lady with a tumor involving the main bronchus, and in normal circumstances, this patient is supposed to go for a pneumonectomy. And pneumonectomy on the right side carries high morbidity. So what we do instead of pneumonectomy, we perform a sleeve lobectomy where you take out the affected lobe and the bronchus, reconstruct the non-affected lobe and attach them back to the right main bronchus. And this is performed by vets. And we didn't do open surgery. It's the first case performed in HKL by a uniportal vets, probably in Malaysia. So this is the bronchus that we cut off. This is the bronchus going to the lower lobe and middle lobe. And once this is divided, the affected is, the lesion is in the upper lobe. Here's the tumor, you can see, the nodes. And then later on, I'll show you, that's the tumor in the main bronchus. So, and here is your right main bronchus, and that's the trachea. So we need to resect to get the margin, at least 2 centimeters. So that's the tumor. You need to get at least 2 centimeter margin to the main bronchus. So we've removed the lobe and the tumor, and I inspect the margin outside. I'm not happy with it. I cut further towards the trachea and the carina. So most thoracic surgeons are worried to do any surgery near the carina, let alone resect the carina. So that is the reason why these surgeries are rarely performed before this, but now we can do it by manner of video-assisted thoracoscopic surgery. So then you reconstruct the main bronchus, the right main bronchus, to the remaining lower lobe and middle lobe bronchus. We call it the intermediate bronchus. We anastomose it intraoperatively. This whole surgery took me about 5 hours plus to perform. It's technically challenging. It's a complicated surgery, and there are a lot of areas that we need to be careful about, especially right in front of the screen. Here is the pulmonary artery, and my needle is going around behind the pulmonary artery, and I can't injure the pulmonary artery. So the drive of the needle, the direction, the amount of energy to be used constantly for the half an hour or 45 minutes I'm doing this anastomosis must be always controlled. It's a complicated surgery, but performed successfully. And the patient, as of now, still recurrence-free. It's almost a year plus now since we performed the surgery. So this is where the part where we anastomose, the anastomosis of the suturing of the main bronchus to the lower lobe bronchus is complete. And we're testing the air leak, whether is there any air leak or not, by expanding the lung. And this is a specimen with the tumor here. And this is the chest X-ray of the patient after the surgery. And this is a bronchoscope of the patient. So this is the size of the lesion, incision that we use to perform this entire surgery. And it's a complex surgery, and it takes a long time to perform, complicated. I would have done early cancers anytime compared to this. But the problem is we can offer curative surgery in this day and age, regardless of what stage they present. If they are indicated for surgery, we can look into it. So a little bit about what we do in HKL. I started the service in HKL since 2017. I was trained by Mr. Hari and Mr. Prem from Penang and Sungai Petani. And the outpatient clinics are every Mondays and Thursdays from 2 p.m. onwards. The elective operating days are on Tuesdays and Fridays for 12 hours. We have our lung cancer MDT with IPR on Tuesdays every fortnight. We have our chest wall tumor group. So I think the only center in Malaysia undertaking complex chest wall surgeries. We have referrals from all over the departments in HKL and also hospitals around Peninsular Malaysia. I do ad hoc visits to other KKM hospitals to perform thoracic surgery as and when needed. We have published few of our work. This is on uniportal video-assisted thoracoscopic surgery in our unit. We performed 170 cases at the date of publication. And a few other rare case reports on lung sequester. This is probably the second case reported in the world, primary lung carcinoma with tracheal bronchus treated with uniportal video-assisted thoracoscopic surgery performed in HKL. And this is the surgery that I mentioned just now, the first experience in HKL on right upper sleeve lobectomies. This is our recent publication on the chest wall series. We performed about 20 chest wall resections at the time of writing. As of now, we've performed about 35 resections. We just did one 3 days ago. And this is some of the cases that we showed in the journal. So how to get referred to our unit? A simple referral letter from the primary care physician will do, and bring along the scans and reports. You don't need a biopsy to be referred to my unit. We will do the biopsy as and when needed according to the size of the lesion, accessibility, and we may even carry on with the surgery with frozen section if our radiologist says it's difficult to biopsy the lung because of the size and the location. Clinic days are on Mondays and Thursday afternoon, second floor in the surgical outpatient department. That's where the thoracic clinic is. For lung cancer, surgeries will be performed within 3 weeks from the date of clinic visit or from the diagnosis of the histopathology. So this is our KPI that I have set for my unit, and so far we've been able to keep to the KPIs. With that, thank you. I will be happy to take questions. Dr. Murli, are you there? I think you're muted.
Okay. Sorry, I couldn't unmute myself. Okay. Thank you very much, Doctor. I think it was very enlightening, and some questions, let's address that first. Actually, I think this was from the kind of the earlier segment, Doctor. I think one doctor is asking, does the prognosis depend on the type of lung cancer?
Yeah, I mean, I think we've discussed that on the between squamous and adeno. But if you look at the non-small cell, small cell, and large cell lung cancers, most of the surgeries are performed for non-small cell lung cancers because their prognosis is relatively better compared to small cell and large cell lung cancers. So yes, non-small cell lung cancers carries better prognosis compared to large cell and small cell lung cancers. Within the non-small cell subtypes, the squamous cell carries poorer prognosis as compared to adenocarcinoma of the lung.
Right. Doctor, I think Dr. Yo asks a question on why actually your thoughts on why the survival rates in China are so good.
Well, as I said, number one is the awareness. I think somehow the Chinese have better awareness of their lung cancer, chances of them getting lung cancer, because number one, the pollution in their country is higher. So they all wear masks even before the COVID-19 started. And I think they have many designs in their masks. So their awareness of the lung diseases is way higher compared to us. Number two, the cost of LDCT in at least in Shanghai, to my knowledge, when I visited there, as I said, is about $40 US. That translates to about 120 to 150 ringgit Malaysia. That's very cheap for the cost of performing an LDCT. So I would not hesitate to perform the scan if I go for a medical checkup in any hospital. All they need to be informed is the doctor offering them the medical checkup. Would you want to add LDCT because you're in the high risk group? And all they need to, how much is it? That's the next question they'll ask. When he says about 200 ringgit, they won't hesitate because it's covered by the insurance anyway. So that's another reason why I think their detection is much higher. Thirdly is the expertise and infrastructure. They have a whole building for thoracic center alone, and thoracic diseases are treated in a one-stop center. And they have 20 operating rooms running simultaneously, 30 over-thoracic surgeons in one hospital performing 90 to 100 lung resections every day. So why wouldn't their outcome be better? Of course, their outcome will be better. In fact, I'm surprised if their latest result shows 90% 5-year survival for stage 1, if not 100%. So those are the few reasons that I noticed during my visit to Shanghai. And I think we should look into how the Taiwanese, Chinese, Hongkies are performing way better. Instead of sending our trainees to Western countries, we should send them to these countries to learn how they detect early, how they do the simulation of the scans, and all the instruments and the facilities they have, we also have. It's not that we don't have that. It's just that the mindset and the ability to generate reproducible workforce is not achieved in Malaysia yet.
Right. Got it, Doctor. Doctor, there's another question on what is the risk or incidence of recurrence post-lobectomy for early lung cancer?
Well, it's low. As I said, the 5-year survival for early lung cancer, for example, stage 1 is up to 80%. That means the incidence of recurrence, progressive free survival that we are looking at is less than 10%. Means you have chance of not getting the recurrence as high as 90% in your 5 years.
Okay. So that's really, really good numbers, yeah.
So detect early, you'll be good.
Yep.
Yeah.
Got it, Doctor. There's another question from Dr. Christine. In women above 40 years old, non-smoker, family history of cancer, Southeast Asian, these criteria, quite a lot of women actually fulfill these criteria. Should there be some symptoms like loss of weight, cough, dyspnea before we kind of refer them for a low-dose CT?
No, I don't think you should wait for symptoms. If you wait for symptoms, it's too late. Because once the tumor manifests its symptoms in terms of loss of weight, that means the disease has gone systemic. So at that point, it's already a late stage. They may already have metastasis. So if they, I agree, it's a huge population to cover if you look based on the criteria. That's what makes the screening very challenging. And the only way to detect early is not wait for screening to pop up. We need to take it in our hands and perform LVCT as part of a medical checkup to detect lung cancers early.
Right. And perhaps to kind of give a little bit of good news to what Dr. Nara is saying, I'm not sure whether our colleagues are aware that I think one of the, maybe I'm very careful with my words, one of the few things which seem to be of positive note in the budget is that they're increasing the reimbursable for medical checkups. The nearest we can get to screening to about 1,000 ringgit per individual against your income tax deductible. This kicks in from January, so that might be an additional kind of motivation that you could use to incentivize patients to actually go and get a low-dose CT if they so require it. Isn't it, Doctor? It may help to offset the charges in that sense.
Yeah.
Yeah. Doctor, of course, another question which is I think you're bound to come up with when we talk about early detection is the idea of tumor markers in kind of predictive value against early detection of lung cancer. Any thoughts on Doctor?
Yes, they have liquid biopsy nowadays where you just take the blood and check for circulating tumor DNAs and so on, but that's not in the diagnostic purpose yet. As of now, we do check CEAs, carcinoembryonic antigens for lung cancers, but it is not specific. It may be raised in colon cancers. It may be naturally raised among smokers, so you can't really say. So there's no one tumor marker with high sensitivity or high specificity that is easily doable in our healthcare setup at the moment.
Right. Will do, doctor. Because of course, again, there's this tendency for everyone in terms of patients, they of course like it when you can just tag on a blood test and then they feel that, oh, I've sorted out my life responsibilities in
I wish.
screening for lung cancer. Yeah. There's another question on, and I think Dr. Nara did share about this. Currently with the Lung Cancer Network, there is quite a good option of free screening. But Dr. Christine is asking where would be the cheapest place for screening LDCT at this point in time. Any ideas, Doctor?
I'll share the screen again with the thing. I think they are offering for free lung cancer rather than cheaper. I'm not sure exactly is it cheaper or not because I have no idea about that. But for the free lung cancers, just hold on a bit. I'll share you the screen.
Yep. Oh, thank you, Doctor. Because Dr. Christine, Dr. Nara did put up the poster earlier. Lung Cancer Network Malaysia is actually working with quite a few private hospitals as partners to provide low-dose CT screening at this point in time.
Okay, this is the screen. I hope you guys can see. You can snapshot the screen for your information, or you can just go to Facebook and look for Lung Cancer Network, and this screen will pop up. There's no, and you can use it at your convenience later on. So I don't know how much it costs, where it costs cheapest. I just know that based on this promotion, it's free. Yep. So when it says free, I think everyone gets excited. So please go and get the scan done.
Yes, doctor. And I think it lasts until the 31st of December. So you've still got time to kind of convince some of your patients to kind of put themselves on the test if they so desire and you know if they so merit that kind of risk assessment. Doctor, there's also kind of another curious question which I think is worth sharing about with our colleagues as well. So now there are some centers which are offering a kind of investment plan where you actually buy every couple of years once they put up a cardiac MRI for you. So you pay like a membership and then you get on to this plan, and then you know, every about I think 3 years or 5 years they give you a cardiac MRI and a few other things. And so some queries to us also in the past whether these cardiac MRI, is it good enough to kind of detect lung cancer since we're already paying for it?
I'm not very sure whether the cardiac MRI is good enough because they'll be concentrating on the cardiac. You may incidentally find lung cancers that comes in the vision of the cardiac MRI. And when MRI should be more sensitive in detecting nodules in the lungs. So if you're doing a cardiac MRI and you're covering the entire lung field, then yes, it will be able to detect lung lesions. But that doesn't mean that all of you should just go ahead and do cardiac MRI and hoping that instead of detecting cardiac disease, you'll come up with a lung lesions. The indications for cardiac MRI is totally different from low-dose CT scans. So you may not sample the right population to perform the investigations to detect those diseases early. And also keep in mind that if you're indicated to perform a cardiac MRI, you may not be fit to go for surgery. So, yeah, because you have a cardiac condition and that's why cardiac MRI was suggested. So if there's any abnormalities in the heart, then we need to investigate that extensively before we subject the patient to go for a lung resection.
Right.
Yeah. So that shouldn't be in the mindset.
Yeah, exactly. Thank you, doctor. There's just one more question. I think it's about whether free screening. Dr. Christine asks, in the poster, the campaign that's being run is for smokers. So how about non-smokers? I think Dr. Christine, what I mean, we'll put it to Dr. Nara as well, but what we'll do is we'll do a little bit of homework and try to give you all a list of pricing for low-dose CT, or hopefully by the end of the year. Give us a couple of weeks to work that out. It's going to be very difficult, I think, for Dr. Nara as well to kind of tell you which hospital is cheaper, which hospital is not cheaper. Isn't that true, Doctor?
Yeah, yeah. This is not what I call we shouldn't be talking about screening per se, because when you use the word screening, that means the physician is taking the responsibility of the lesion that they might detect, and it's not fair to subject the cost of the subsequent test on the patient, because it's initiated by the institution. But if you put it as a medical checkup, it's initiated by the patient, and the patient is obliged to take care of whatever findings from the scans that is performed, and the physicians or the surgeons will assist the patient with the findings that they have in the low-dose CT scan. So I think at the moment it's not about free or low, it's about how much the patient is willing to invest in their own health, in detecting lung cancers early, knowing that they are in the high-risk group. So that's the big question that we need to make sure we can answer out of this short sessions that we have.
Right, right. And I think one of the important sharings that you did today, Doctor, is to tell us that look, surgery is quite a realistic option. And it's because I think for a lot of people, the thinking has now become that due to targeted or immunotherapy, now there's no need to do surgery, actually. And that seems to be quite an idea that's making its way quite popularly amongst a lot of people. Any kind of thoughts on that, Doctor?
Yes, you're right that the research results, like the Pacific trial and other trials that's available on immunotherapy and also trials on targeted therapy, are showing that they can provide good results, significant improvement in the survival of the patient with only giving immunotherapy. But again, how many of our patients with lung cancer can actually afford paying 200 over 1,000 a year just for immunotherapy, and they're not even sure whether 1 year is enough.
Right.
And if you can afford 200,000 ringgit per year, then by all means, please carry on with the treatment, because the results have shown that it is equivalent or better than providing surgery. But there's no head-to-head comparison at the moment. The evidence that is shown is for unresectable cancers, and people are trying to extrapolate these results for resectable diseases as well.
Excellent. I think that's the kind of how to say insight that word that you were saying on the difference between resectable and unresectable cancers. And in fact, I think the terminology or kind of the thought process should be, look, surgery is as good as if as these highly expensive therapies at perhaps maybe about 20% of the cost, or 10% of the cost.
There's been a study that's performed in the US back in 2015 on cost-effective analysis for surgeries performed in lung cancers as in stage 3A, where you can either do surgery and chemotherapy versus they looked at the arm where they went for definitive chemoradiotherapy. And the incremental cost effectiveness ratio that they calculated in their study showed that performing surgery in stage 3A lung cancer is cost effective in both academic and non-academic centers, as compared to subjecting the patient only chemoradiotherapy. because in terms of increased survival benefit that they get, the patients get, they found that it is cost effective to perform surgery.
Right. Well done, doctor. So there's just one more question. I'm going to take that for you, and then also really in advance, thank you for taking so much of time with us today. If the low dose CT is negative, doctor, how frequently should you repeat the low dose CT?
Normally, if the low dose CT is negative and you are a high risk group of patients who perform the low dose CT, you can repeat it 2 yearly.
Okay. So and to
provided you're not symptomatic. If you're symptomatic, then you need to intervene earlier. If you remain asymptomatic and you continue smoking, repeat the low dose CT 2 yearly.
2 yearly. And so really to share with the rest of our colleagues, lebih kurang in the market is about 700 to 800 ringgit lah for a low dose CT. So we're looking at about 800 ringgit over about 2 years. I think, again, as a value proposition to the patient, I think it's something that if nothing from today's session, I think Dr. Nara has convinced us to, make that extra step to kind of speak to patients about it. Worth to kind of invest to pick it up early. Okay, Doctor, I again would really like to thank you very much for having spent quite a lot of time with us and patiently answering all our questions. I'm going to ask you if there's any kind of takeaways that you want to leave us with.
The takeaway message is simple: detect early, treat early for better outcome.
Right. Okay. So lovely. Short and sweet. As they would say in a Bollywood movie, that was the punch dialogue to go with. Okay. So, ladies and gentlemen, so thank you very much for spending your Saturday morning with us today. The second code word, I think, again, this is very kind of in homage to Dr. Nara's talk, is VATS, V-A-T-S. So feel free to kind of fill in the second code word. As usual, I'll always be nice and give you the first code word as well. So the first code word just now was low dose CT, and the second one now is VATS, V-A-T-S. So kind of please put that into the attendance. Thanking you all very much. As usual, the video will be on YouTube by the end of the day. We'll also send you the link. We'll put it on the Facebook, both I think the MMA Facebooks as well as the National Cancer Society Facebooks. So feel free to continue watching and sharing. And if I will leave open the CPD kind of forms open for a week still. So if you haven't managed to watch it today, you haven't managed to follow us today, feel free to kind of watch the video. You've got it on for the rest of the week until the end of next week. So thank you very much again, Dr. Nara, from our side. And thank you very much for also sharing quite a lot of detailed information of how to get in touch with the thoracic service in HKL and how to send patients to y'all as well. As usual, I mean, really, doctors are the only people who will ask for more work. So I think you've opened the door to do a lot more work.
I really hope I haven't opened the floodgate.
But I think, I think it's something that your team is very willing to do, and we thank you for that as well, for the dedication and kind of the commitment to serving all of us. Thank you so much. So have a wonderful weekend, and in advance, Merry Christmas and Happy New Year as well. Thank you very much.